Welcome to Essentials of Acute Care. I am Dr. Sunil Garg. In last several videos, I discussed how to initiate invasive mechanical ventilation in adult patients. During presentation of these videos, I used several different terminologies. In this video, I will discuss about those terminologies in more detail to better understand the concept of invasive mechanical ventilation. Predicted body weight. The calculation of predicted body weight is used for calculating target tidal volume during mechanical ventilation of ARDS patient. Here you can see two different equations for male and female. Permissive hypercapnia is a ventilatory strategy which accepts alveolar hypoventilation in order to maintain low alveolar pressure, so the complication of alveolar overdistension can be minimized. The resultant increase in partial pressure of arterial carbon dioxide can be decreased by increasing the respiratory rate to the extent that there is no auto-PEEP. This strategy is used while ventilating patients with ARDS. Another situation where strategy of permissive hypercapnia is used are patients with obstructive airway disease. In this condition of obstructive airway disease, permissive hypercapnia facilitates the reduction of dynamic hyperinflation or auto-PEEP during mechanical ventilation by allowing an increase in the expiratory time by reducing the respiratory rate, decreasing the tidal volume, or increasing inspiratory flow rate. Auto-PEEP occurs when air flow does not return to zero at the end of exhalation and new inspiration begins. It usually occurs during mechanical ventilation of patients with obstructive airway disease. In this condition, expiratory airflow is too slow to allow complete deflation of the lung to its normal rest state before ventilator delivers next breath. Auto-PEEP can also develop in patients of ARDS on low tidal volume ventilation, where respiratory rate is increased to compensate for the rising CO2, and high respiratory rate decreases the time to complete exhalation to occur. This is flow time graph depicting auto-PEEP. Here you can see expiration with the yellow line is not touching the violet line. Ideally, this yellow line should touch the baseline at violet line, and this red line should start from the violet line rather than from the yellow line directly. It means patient has auto-PEEP. Driving pressure. Driving pressure is the ratio of tidal volume to static respiratory compliance, and it can be calculated at the bedside by subtracting the value of PEEP from the plateau pressure. The utility of driving pressure while ventilating ARDS patient yet to be subjected to high quality randomized control trial confirming its clinical utility and safety. The rationale behind clinical utility of driving pressure lies in the concept of baby lung, means varying proportion of the lung is not available for ventilation in ARDS patient. And according to ARDS NET protocol, target tidal volume is based on predicted body weight. And this decrease in the available lung for ventilation manifests as a decrease in the respiratory system compliance. For example, if two lungs are of same size but the first lung has lower respiratory compliance, then the delivered tidal volume calculated according to predicted body weight will cause more mechanical stress in the first lung than the more compliant second lung. So the impact of tidal ventilation or lung injury could be better predicted if tidal volume is normalized to respiratory system compliance than to the predicted body weight. Thus, normalizing the tidal volume to respiratory system compliance and using this ratio as an index to functional size of the lung may provide a better predictor of outcome in patients with the ARDS than tidal volume alone. And this ratio is termed as a driving pressure. Here you can see pressure time graph, and here you can see the difference between the plateau pressure and the PEEP is the driving pressure. The current estimate for safe driving pressure range from 14 to 18 centimeter of water. Transpulmonary pressure by definition is the net distending pressure or the pressure needed to keep lung open, and it is the difference between alveolar pressure and pleural pressure. What is the significance of transpulmonary pressure? Transpulmonary pressure determines the influence of chest wall on airway pressure. So transpulmonary pressure is the pressure which is delivered to the lung and required to keep the lung open, and it is independent from the effect of chest wall and abdomen on the airway pressure. Conditions that decrease chest wall compliance can increase airway pressure and lead to false impression that lung stress is present or lung stress has increased. In such situations, measuring transpulmonary pressure can more accurately reflect the stress on lung parenchyma, as the measurement is independent of chest wall compliance. So you can ventilate such patients above the accepted airway plateau pressure if transpulmonary pressure remains within normal limit. Thanks for watching this video. If you like this video, please subscribe to it. See you in my next video on ventilating ARDS patient. Till then, thanks and bye.